they're writing stuff down, or no, you've got a spokesperson.
But I will repeat the question, and then that'll give you another minute or two. Because I'm going to try to
Take a bunch at
take
a
a
time.
yeah.
It's always nice because
Right.
then you don't have to answer every single question as well. Unfortunately, sitting down here, you can't see out
Right.
because of the.
And if you, for this part, I think if you want to go down, it's perfectly fine. You can take, I can give you one of the handheld mics. We'll be okay. Take another moment and have your spokesperson prepared, please. Take another moment and have your spokesperson prepared. Okay, good. Great. Right. Let me have you pause where you are. Finish your sentence or comment. Let me have your attention, attention, attention. So, we want to take advantage of your questions and comments. And I'm going to start. I'm about to start. Maybe. I'm going to start in the middle of the room. Let me have your attention. Thanks, Jody. I forgot to bring my noisemaker, so you'll be my surrogate. We're going to start in the middle of the room, and I'd like to start at table 8, 7, and 4. I'll pause there, and I'll take either a question or comment from table 8, 7, and 4. Then I'll come to 3 and work either the left or the right side of the room. So who's the spokesperson at table 8? And tell us who you are so that we will know that. And then if you'll give us one of your questions or comments, that would be helpful.
Yes, good morning, everyone. I'm Helena Valkowiak. I work for Management Sciences for Health. I work on the SciAps program, the USAID-funded Systems for Improving Access to Pharmaceuticals and Services. So we had a lot of discussion. We thought it was a great, and you did a brilliant job on synthesizing and presenting the evidence. We kind of, there were a couple of discussions around, we understood that you showed us that there were correlations between improvements and health outcomes, but then there was the question that there wasn't a lot of evidence. So we kind of understood that to mean that that we need more information on what actually works. So although the correlations exist, we don't know how they work. So we just wanted to clarify that. The second thing, in terms of wanting to look at the evidence, a big question in this room is, as an investor, USAID and as technical advisors who go to advise governments, we really want to know, well, where should we put the funding, advise to put the funding in order to make improvements to health outcomes. So as we move forward with this very empty canvas, that would be maybe one area to focus on. The question, we had one question for you in that health is one of those areas, particularly in the countries where we work, where the government is a direct provider of services. And the other sector where that happens is education. And so there was a question of whether there's any evidence from the education sector about governance and what might work. And in defense of randomized controlled trials, we felt that they may be expensive, but they do give a definite answer. But I think as a group, we recognize that mixed methods is the best way to go. And is there any, the next question would be, from this incredible evidence, are there any hints of the next level of specificity of where we ought to continue? Thank you.
All right, thank you. So there were several questions in the air, and let me just have you give me a succinct summary of what the questions are.
First one is, given the incredible evidence, are there hints of where we should, given the incredible evidence, are there hints of where we should next focus, some specificity, particularly given that the interest in linking, knowing where to invest in the room? And the second question is, are there some lessons, some evidence from the educational sector?
Thank you. Let me come to table number 7. If I could get one of your 2, that would be helpful.
Hi, my name is Scott Stewart. I work with USAID in the Office of Health Systems. And one of the points that we raised was the need to document the conditions under which governance interventions do and do not work. With the political economy being one in particular, this came from a discussion of the question, are there times when it's just not worth it to invest in governance interventions?
Right.
So there we are.
Thank you very much. And one from table number 4.
Hi, my name is Reshma Trasi. I'm the Director for Monitoring, Evaluation, and Research for the Leadership Management and Governance Project. I think we had a fair distribution of people that almost applauded you when you said, can we step away from RCTs, and those that didn't. So I think there is a comment and a request to perhaps look at what RCTs are being done in other parts of USAID and the return on investment on those. But I'd like to offer up one that's perhaps similar to what Helena was talking about, looking at other disciplines for design options. For example, looking at management theory or political science, and education was the other one that came up as well. So looking at what those fields might have to offer And then I think I should add kind of into this piece, and perhaps for broader discussion later on today, the element of feasibility and the practicality of where USAID investment needs to go and where missions are going to be willing to invest their funds, which I think is something for us all to keep in mind as we drive this conversation forward. Thank you.
All right, thank you. So I'm going to give Sarah an opportunity to offer some reflections, and then if someone else in the room would like to offer a comment on either of the questions, that's certainly expected and desirable.
So I will be really brief because I think it's actually more interesting. I've talked for a lot. It seems to me that several of you are asking a somewhat similar question about, given how blank a canvas this is, where do we start? Are there some conditions which, some countries where it simply doesn't make sense to proceed? And I think you're right to sort of raise those questions about, under which conditions would investment in this field make sense? And clearly, the irony here is that the countries with the weakest, most dysfunctional governance systems might be the ones that need it most, and yet might be the ones where it's hardest to really get some traction. I don't want to speculate about where you should start, because I think that there are at least half a dozen really pressing needs here that I could think of sort of off the top of my head. But I think it has to be a collective decision about, are we really interested in strengthening financial management, which would have benefits across the board? Are we more interested in strengthening community accountability? They're all really different kind of directions to go in. And I think it's a question of sort of what makes political sense, as well as what's practical. Questions about the links to other sectors, I agree, you're absolutely right, but I think that there are other people in this room who are generalists rather than health sector specialists who might be better at commenting on that than I am. So I'd prefer that they respond.
Yes. And we need a mic over here.
Ross Herbert, I'm quite the generalist from the Africa Bureau. I spent a lot of time living there. One just answer to the education question. There was a study done in Uganda, and there was a certain category of funding that flowed down to schools from the federal government, and they found that 80–90% of it was missing. And so one trial was to simply post in varying places and varying distances from villages information about how much money was supposed to be going to these schools, and found that there was a measurable impact on the reduction in corruption by simply putting some information out there. And they tried to put it in a newspaper, just post it on the side of a building, various permutations, which raises to me some obvious suggestions about the applicability for clinics. And if you had rating information of any kind, that doctors are absent this much time, or this much medicine goes missing, or other attributes of performance that you simply put there, that would be. Sometimes accountability systems don't have to be terribly fancy. They can be simple. Another one that was a huge impact in South Africa, that you could have all the fancy technical systems you wanted, but when it came to HIV, the underlying level of understanding about where does disease come from, and the fact that it's usually thought of as something, a pox put on you by somebody else. It's not conceived of as something that you yourself could bring on yourself, and that brought a level of embarrassment to think that you got HIV from something you yourself did. I always thought it would have been the most obvious intervention to just have a microscope in a school and allow people to see there's little beasties swimming around in the water, there's stuff you can't see, and you got to try to keep it outside of your consumption. And opening the doors of there's things in the invisible. The way common culture is explaining the invisible is through all kinds of superstitions and witchcraft and other reasons, and the technical health field wasn't very good at ever dealing with that. So once you open the door of understanding, then people use their own energies to protect themselves and heal themselves, rather than anyway. There's some things that can be done with that. And a third example really goes to the importance of dialogue, where you have to encourage and cultivate people's understanding of why you're trying to do what you're trying to do. And often we rush ahead to the intervention and the technical solution, and sometimes it takes a lot of jawing in the village about why this should work and how it should work and why are we doing this, and that might go on for an interminable amount of time, but once it's done, then people begin to be able to be a citizen able, they can assert themselves because they understand why something's supposed to be, and often that's just bypassed altogether.
Right. Thank you. I'm going to come over to table 5. We're going to be time constrained, so I'm going to take 1 from 5 and come over to 2. Then we'll have to pause. If I don't get your question, please write it down on the index card that we just passed out so that we can at least collect those. So 5 and then over to 2.
Okay, we had a lot that we were talking about at this table. I think one of the points that Jeremy raised that we think is really important in thinking about research in this area is that we noticed that in one of the slides that you had, Sarah, you had all the arrows pointing in one direction, right, in terms of the impact on governance, on health outcomes. Should we not also be thinking about how we turn the arrow back in the other direction? So in other words, to the extent that you are actually improving service delivery, to what extent does that have knock-on effects in terms of public perceptions of legitimacy around governance, which is something as a DRG person I think is a really interesting question to look at as well.
Thank you. Table number 2.
Thank you. I think some of the
Step forward so that everybody can see you. Otherwise, you're blocked by the pillar.
Anyway, I think our group really loved your presentation and overlap with what's been said about learning from the other disciplines. Maybe what we haven't heard yet, there was an observation that there seemed to be a gap in terms of the policy-making process, the decision-making process, evidence-based decision-making as a aspect of governance that we didn't see reflected there.
Thank you. Comments, Sarah?
They were both great questions or comments. I agree with you entirely about the interest in seeing lines going back the other way, and I think particularly in sort of post-conflict settings, people are very interested to understand how you can sort of start at the grassroots level at building services and how that affects trust in government and perceptions of the legitimacy of government. I think somehow this workshop was framed in such a way that led me to go in the opposite direction, but I agree with you, that direction is also important.
I can comment on that.
Yeah.
Just really quickly, I think, and Anne just whispered to me, we could have arrows going in all directions. I think we could have arrows going in all directions. I think, we just wanted to focus on that aspect because for health, it's really critical that we demonstrate those investments. But I think, for DRG, and Laura, I don't know if you introduced yourself, but it's Laura Pavlovich from DRG who will be on a panel later today. I think we would be interested if DRG has evidence on the other side. I think we'd be interested in that. But for today, I think we were interested in that, and I think you raise an interesting point for future. How do we do that in the future? Because the two-way arrow certainly is really important.
Thank you.
Catherine's comment very briefly, just because I think that when you start reviewing the evidence base, maybe there's a bias there because it's a bias towards the sexier topics, the sort of community health councils that have had big impacts on infant mortality. But I think you're pointing to sort of the bread and butter business of government and governance, which I had one slide on, which maybe I should have had more on, because I agree with you. I think that evidence-informed policy, brokering relationships between public and private sectors, building coalitions, those kind of things are really key to making government overall more effective in health. But it's sometimes harder to trace the impact on how they connect to health outcomes. And maybe that's also why there's fewer studies in that space.
Thank you. We're going to pause here. And again, if we didn't get to your question or comment, please write a note so that we can assemble those. We're about to move on, and we're going to be looking now at some of the ongoing activities that are in fact focusing on evidence generation. Let's give Sarah another applause. And as my esteemed panel assembles itself, I want to give you 5 minutes to stand and stretch. Don't go far away because we're going to start in 5 minutes. And those panelists can come up front. That's going to be Joe, Nicole, and Dennis. Joe, Nicole, and Dennis. right. Where are they? I was just reminded there are restrooms, and they're just around the corner. Hi, Joe. My pleasure. And how do I pronounce your last name so that I can get it right?
Namoli. Forget about that I. Just
All
say
right.
Namoli, as it's N-A.
Nomoli. All right.
Hi, Nicole. Nicole,
Right.
on off.
All right.
Hi, Nicole.
Hi.
How are you? Nice to meet you.
Nice to meet
Joe.
you too.
Did Jeremy establish who goes first, second, and
I
third?
think I'm first.
All right. Well, maybe
Yeah.
it's like this.
Yeah, yeah.
Okay.
And then Nicole, and
So Nomoli.
then Namoli.
Nomoli. Nomoli.
It's funny too because usually I was joking with the woman who was preparing her things. And
Right.
Usually everyone misspells my last name. I
Right.
forget that I. She misspelled my first name, so the Joe is fine.
You're doing so well. There have been several people who come up to Sarah and just said, when can I get a copy of that?
Right.
So would you just let people know we'll send it out
Right,
to them?
I will. That's a good reminder. Yeah. Okay. Electronic copies coming.
Yeah, yeah.
And do we have everybody's email?
Oh, that's
Yes,
a good
sorry.
point. Make sure that if anybody didn't RSVP, they need to,
Give us their.
give us their
Okay,
email
all right.
to whoever. I don't know who that would be. but
We'll work something out over lunch for them to
yeah,
give it to us.
if they've RSVP'd,
Right.
we have it, but
All
if
right.
they haven't.
Okay.
Yeah, thank you.
All right. Thank you.
He's from Afghanistan. He's never like this was several years ago when he was a fellow here. He said it's kind of like cricket, and there are a lot of people here.
We're gonna have one more. Dennis. He'll be at the. So we'll have three. And this will be our first person. And then Nicole will be our second person. And Dennis will be the anchor person.
Yeah, it was
Or the
well.
cleanup
There's
hitter.
that new cricket now.
He is.
2020. Everybody's
They're going to have 10 minutes each. I
Uh,
talked with Jeremy, who said
10.
10 or 12 minutes.
right. So we probably need to do 12, I think.
Right, so if we do that, then that'll give you about 15 minutes before we break for us.
Additional, right?
That'll be enough time.
Well,
It'll
we'll,
be what it is.
yeah. That's about it.
How you feeling? You need anything?
I'm good. Obviously we're a bit behind. That's the way life is. The woman who came up to me, she used to be the health director in Uganda. She's standing with me here for 2 or 5 months. Her husband had it early on. He said,
Many years
and
ago.
passed away. He was probably doing, when it first happened, he was probably in the late 20s. I think probably was only about 60s, mid-60s when he passed away.
Probably not appropriate year for me.
And then the one that was for 70 is plagued by cancer. Probably only has months. The process is a challenge.
He's on
When I crack the whip.
right now, actually in Zambia, working on the program that I'm going to be talking about. So that's why he couldn't be here. Because we have
We're about to get started, so you can return to your seats, please. So, if someone standing near the door can get those outside in, that would be helpful. Dennis, we're waiting for you. Dennis, you're desired up front, sir.
Hi, Joe.
Okay, here we go. We are going to make Sarah's presentation available electronically. If you RSVP'd, we have your email address. If you didn't RSVP, we'll need to get your email address. And you can leave that out at the registration desk so that we can get Sarah's presentation to you via electronic exchange. We are now going to move forward, and we're going to look at some of the activities that are already being undertaken that are mapping your ongoing evidence generation activities. And we've got a very distinguished panel, and we're going to start with Joe, and then we'll go to Nicole, and we'll finish with Dennis. You will note that I did not try last names because I'm not necessarily a quick study in pronunciation, and I didn't want to blow it. So I'm going to allow them to give you their full names as they come forward. They'll be speaking for roughly 12 minutes or so listen closely. At the end, we realize that there are some other activities that they may not touch on, so we're going to open it up for you to share some of the things that you're aware of beyond what the panel will present. So I'm going to start with Joe, Nicole, and then over to Dennis.
Thanks very much. That was a very nice, smooth move away from pronouncing those last names. That was very, very, very nice. I have to remember that for the future. My name is Joe Namoli, and I'm the Health Systems Research Advisor in the Office of Health Systems at USAID. And I just wanted to say that I wanted to take a small step back from Sarah's presentation, which was, as we've come to expect, a very inspirational and comprehensive and informative presentation. I'm taking a small step back from that, and what I want to do is I want to put governance in the context of a broader body of work that has just emerged recently that USAID is supporting related to health systems research that I think is particularly relevant to this group and also is relevant and actually a priority for our senior leadership in terms of improving our evidence-based decision-making. So you'll see, I think, how this is pertinent to what you're involved with, but it is a bit of a step back away from just the governance part, but you'll see how I think that it has implications for governance in every way. So first, as everybody in this room knows, that the evidence on health systems research is scarce, scattered, and it's not widely disseminated on how interventions to strengthen and sustain improved health system performance contribute to sustained improvements in health status, particularly toward ending preventable child and maternal deaths and fostering an AIDS-free generation. But without this evidence, decision makers really do lack a sound basis for investing scarce health funds on health system strengthening interventions in an environment of competing investment options. The evidence gap is a significant one because it hinders our ability to get support from the US Congress, from PEPFAR, from USAID Global Health Element Fund stewards, from mission health officers, from counterpart governments, and other stakeholders. So in response to this challenge, our office has taken a two-pronged approach. The first is to gather, synthesize, and disseminate the available evidence, and some of you have probably been involved with some of our evidence summits up to this point, either as a participant or maybe you have read some of the documentation coming out of that. And the second prong is to identify and take steps to fill gaps in the available evidence through new research. So we've mounted an initiative, which is on the screen there, which we call Marshalling the Evidence on the Impact of Health System Strengthening on Health Outcomes, which actually brings together some new activities, but also grandfathers in some existing activities, things that have already been in process. And this is an effort that Scott Stewart and I have been asked to coordinate. So the two of us are working together on this. And as you'll see, it's quite diverse, and there are a lot of people involved in a lot of activities. So I'm going to talk to you about the 6 activities that are a part of this initiative. 7 activities. 6 of them are evidence-generating activities, while 1 is really more of a knowledge management activity, but I wanted to share that with you. And as I said at the very beginning, all of these activities have implications for governance. Because of the limitations of time, I will only present some highlights from each of these activities, but you can follow up with me during lunch, during the pause. You can send me email afterwards, and I'll be happy to respond to any of your questions. Okay, so here are the 7 activities, and I'm just going to give you some highlights of each one to tell you a little bit about what they are and where we are and what's to be expected. So the first, what we're calling, is an impact policy brief, and that is going to actually be the product of a rapid review of the evidence on the effects of health system strengthening interventions on health outcomes. So a team from HFG right now is making tremendous progress under a very strict time limit. And what they're doing is they're relying primarily on existing systematic reviews drawn from the McMaster University Health Systems Evidence Database. So in essence, what they're going to be doing is a review of the reviews. And most recently, McMaster conducted a search of their database using some domains that HFG provided to them, and it generated a list of over 600 systematic reviews. And these reviews, however, have been evaluated, and in accordance with some inclusion criteria that HFG has laid out, and there are approximately 180 reviews that have remained that are going to be reviewed. So these reviews are now being organized into a smaller set of classifications. Data will be extracted soon. The analysis will occur in August and September, and a draft brief will be produced by September 30th. So as you can see, this really is a rapid review of a huge literature, and we're asking our colleagues to produce this in a very tight time limit. But I have to say, I'm very impressed by the progress that that everyone has already made. So congratulations, and keep up the good work on this. The second is what we call a health system strengthening to health tool. And as many of you probably know or have heard about, the LIST tool, which actually allows users to set up and run multiple scenarios to look at the estimated impact in terms of lives saved of different MNCH intervention packages and coverage levels for their countries, states, or districts. Well, the Office of Health System and our maternal and child health colleagues are working together to develop a tool that will do the same thing for health system strengthening activities. Currently, this is being considered as an add-on to the existing LIST tool, although that could change as more progress is made on the actual design about how to do this. So a meeting has been set up for next week, July 29th, which will bring together representatives of USAID and HFG to move this activity forward. And HFG is currently working on a draft concept note in preparation for the meeting. So this activity, I think, is something that our Assistant Administrator for Health, Ariel, has given particular priority to, and is really looking forward to having the results so that he can make the argument with our health element teams about the value of investing in health system strengthening activities. So this is another important effort that's underway. The third is what we're calling the Health System Strengthening Challenge, to understand the nature and the impact of USAID's substantial investment in health system strengthening. In early July, our office sent out a global call for health system strengthening cases to all global health staff, to the HSS network, to implementing partners working on HSS, and to USAID health staff in the field. And among other things, what the office has asked is that the cases provide project evidence of health system strengthening, but also project contributions to changes in the health status of the population. As of yesterday, our office has received approximately 25 cases from a number of different partners, and the deadline has been extended to this Friday, which is July 25th. And we are expecting at least 30 cases to come forward. OHS staff members, what will happen is OHS staff members will conduct an initial screening to be followed by a more formal review by other offices in Global Health Bureau at USAID. And this global call aims to contribute to the knowledge base about health system strengthening, but also to ensure that lessons learned and successful experiences feed into future programming. So that is the HSS challenge. Number 4 is the Institute of Medicine study, or Institute of Medicine report. So many of you maybe know that USAID some time back commissioned the Institute of Medicine to conduct a study of health system strengthening's contribution to improved health impact. And the audience for this study is the US Congress, as USAID would like to draw public attention to the value of its investment in health system strengthening. The co-chairs of the study team are Julio Frank from the Harvard School of Public Health and Tim Evans from the World Bank. And the draft report was completed on July the 7th and is currently under peer review. The Institute of Medicine has a very rigorous peer review system. So the report is now under peer review, and a second draft will probably be completed by the end of August. And then the final report should be available by September 30th, 2014, in time for the third Global Symposium on Health Systems Research, which will be held at Cape Town. I do not believe that there will be a formal launch of the report because, as I said at the beginning, the audience for this report is really the US Congress. But I think that there will be bound copies of the report available for distribution. And of course, ARIA will be there and other members of our office will be there. So there'll be an opportunity to talk about the report. The fifth is the evaluation registry. An evaluation registry was launched when the new USAID evaluation policy was rolled out in January of 2011. So we now have approximately 3 years of evaluation data that have come from different evaluations that have been carried out of different programs. So a team from USAID completed a preliminary screening of the 54 health evaluations that were conducted from fiscal year 13. And of the 54, they identified 10 that had a health system strengthening related theme to them. And of the 10, 6 focus on one or more health system strengthening interventions for HIV, 3 on multiple or targeted HSS approaches for the country versus one sector, and 1 on health system strengthening for family planning. So our office has identified a 2-prong approach for reviewing these 10 evaluations. One is deductive, in that we have come up with a series of 3 questions that we're hoping to answer. But we recognize that the reports may not provide the information we need to answer those questions. So we also have a deductive approach where we're going to try to extract from those reports what we learn about the evaluations that have been done on changes in the outcome of interest, but also in changes in interventions with respect to health system strengthening. So we don't exactly know what this is going to generate, but we have these 10 evaluations and we don't want to overlook them because we think that they offer some potential knowledge for us that can contribute to this whole initiative. And we hope to finish this review by September 30th, so you can see how we're all kind of on the same trajectory here in trying to get as much done as we possibly can before the third Global Symposium in Cape Town. The next one is the governance evidence activity, which I'm not going to say anything about because that's what we are involved in today. And so as Karen said this morning and Jody said, that we're really looking forward to a very productive outcome from this group in being able to also produce some guidance, some evidence, some knowledge about governance in particular in the broader context of health system strengthening. And then lastly, I just got my little 1 minute left sign, so I'm going to finish up here. Lastly, the knowledge management activity, God bless you. The knowledge management activity is really something that we're calling, and we're still actually working on a name here, but for the time being, we're calling this the ensuring accessibility of evidence. And there are 2 components to this activity. The first is what you might call a supply side component, which consists of a landscape analysis that actually I began in March of 2014. And it's a landscape analysis of current and anticipated USAID investments in health systems research across the entire Global Health Bureau and also across all of our regional health teams. So what we have generated to this point are what we call profiles. So we have 10 draft profiles that we've completed, and each of which describes 1, the current research priorities, 2, the process followed to identify priorities, 3, the mechanisms in place to address these priorities, 4, a summary of the current status of research to answer the questions that are being of interest, and finally, the extent to which these priorities are aligned with similar research that's occurring both within USAID, but also outside of USAID, but within the United States government. And so the profiles are for financing, These are basically the building blocks. Financing, medical products, human resources for health, information. There are 4 profiles for service delivery, one for maternal, neonatal, and child health, one for HIV and AIDS, one for population reproductive health, and one for quality of care. And there is a profile on governance that I've worked with Jody on. It's just, these are all drafts. And finally, there's one for e-health. And we have a research analyst who's working with me right now, and she's doing a cross-profile analysis. We've already have a first prototype that we did that she's working on. So we'll have a cross-case analysis of all 10 of these profiles. And then the second part of this is really more of a demand side component. And so Sarah and Daniela Rodriguez from Johns Hopkins have completed, as Sarah mentioned earlier in her presentation, a series of interviews with USAID mission staff to assess their understanding of health system strengthening evidence, where and how they search for this evidence, how they use it in decision making, and also soliciting their suggestions for how we can make this kind of evidence more easily accessible to them so they can make better evidence-based decision-making, evidence-based decisions. Right now, those data are being analyzed, and in fact, I'll be meeting with Sarah and Danielle tomorrow up at Hopkins to talk about the next steps. And what we are planning, I can tell you now, is that the findings from both of these activities are going to be shared with the people who provided the information or their proxies during a 1.5-day workshop, similar to this workshop, but we're only going to do a half a day in August. And it'll be, the tentative date we've set is August the 25th, but there'll be more information that'll be coming around about that. And the ultimate product of this workshop is really a set of recommendations from staff for how we could achieve greater efficiencies across the health system strengthening research portfolio, which obviously includes governance, perhaps some agreement on the need for identifying a research agenda for the future, and some ideas for how to make evidence more accessible and timely, particularly for our field staff, for improving their decision making. So, as you can see, there are a lot of activities, a lot of things going on. For each of these activities, there's a point of contact, and Scott and I are coordinating with all of those points of contact. We're making progress reports every 2 weeks to Karen so that she can let Ariel know how progress is going. And I think it's a very exciting piece of work that I think we can all learn a lot about from. And so what I urge this group is that obviously governance is going to be filtered through all of these activities, and I think this is something that everybody here should tap into and certainly track, and Jody can be the intermediary for you on these kinds of things. But as I said, if you have any specific questions, things that you'd like to know, you can email me or we can talk afterwards. Thanks very much.
A little shorter. Thank you for having me here today. My name is Nicole Bonoff. I am a Democracy Fellow at the Center for Democracy, Human Rights, and Governance. I'm on the learning team, and my focus on the learning team is randomized controlled trial impact evaluations. So I'm going to tell you broadly about what the learning team is, what we do, what our focus is on, how we go ahead and learn about DRG, and then give you an example of one impact evaluation that we have going on that is in the health sector. So broadly, the learning team, small within the DRG Center, we're about 6 people, all political science PhDs. We use multiple different methods to answer the questions of the DRG Center. We are primarily focused on randomized controlled trial impact evaluations, but we also do broad population-based surveys, and we do qualitative case studies. We have a few thematic areas that we're interested in. I've highlighted the ones in bold that are probably particularly useful in the health sector. So we can think of political knowledge is going to involve messaging campaigns about performance and governance. Human rights is going to affect health because you're bringing in probably disadvantaged populations into the health sector. So, and then clearly, decentralization and local governance and service delivery is where a lot of this work is happening right now. In addition to going ahead and working directly with missions, we have a few other mechanisms by which we conduct our research. We give small grants to academics who go ahead and propose innovative research, and these are about $50,000 grants. And we also go ahead and release targeted research activities that come from the other sector teams. Finally, we've also working on new ways of getting impact evaluations into programs early. If you've ever done an impact evaluation, this is very difficult at USAID because if the mission does not want to do it, it doesn't have to be done. So we have started doing what we call learning clinics. We held our first one in Bangkok last fall. And what we did is we found missions that were in the very beginning of program development, maybe had just completed the PAD or maybe hadn't even, and brought them in, paired them with academics and a member of the learning team and a member from one of the other sectors within the DRG Center. And over the course of the week, they built an activity, the actual activity around doing a randomized controlled trial impact evaluation. So this allowed us to go ahead and make sure that the activity complemented what the design structure was instead of being shoehorned together. So in all, right now, the learning team is managing about 40 different projects. These include, these RCTs, as well as the surveys and qualitative case studies. And then of that, about 24 of them are RCTs, and we're probably going to be adding another 8 or so RCT impact evaluations in the next year. So what does an RCT impact evaluation look like in DRG? We would argue that this is probably maybe the most important form of evidence building that we need to do as a sector because we have such limited information about what actually works. This might be controversial, and people can go ahead and can disagree. But what we're doing in Zambia is we're going ahead and working with the Health Bureau to look at how does good governance increase the supply and the demand for health services. We are doing a 5-year project. The first few years will go ahead and be run as a randomized controlled trial, and then after that we'll figure out which of the different treatment arms was the most successful, and then roll that out more broadly. We wanted to go ahead and do this because there was a lot of interest with the Health Bureau to address this. Clearly, this is why we're here at this conference, that governance is one of the main contributing factors in service delivery. So how can we go ahead and create an enabling environment through citizen pressure to produce better health services? This design, this program is based off of the Bjorkman and Svensson paper that Sarah mentioned. So what Bjorkman and Svensson did in Uganda is they went in to about, I think it's 50 villages, and they held very, very intensive sessions. They created scorecards for every single local health clinic in that area that provided both absolute and relative measures of success of that health clinic, both to other communities and to national and international standards. And then they also facilitated multiple different community member service provider meetings to let community members go ahead and state what were their priorities, what did they need out of their health system. And they also went ahead and made sure that they had multiple meetings for multiple different types of people. So women were able to have their own session, disabled people were able to have their own session, minority groups to allow different people to feel comfortable expressing what they needed. Then the NGO that they worked with went ahead, collected all of these different recommendations and comments and complaints, and provided a work plan for the community clinic to then work from. After 1 year, there was great improvement. We see more people being able to get services for their children, decreased mortality for children, better access for mothers. This seems like this should be a great success. However, this success hasn't been replicated yet, and we want to know why. Why has this this seemingly very amazing project not been able to be reproduced. Probably the most obvious reason is that this is a very intensive intervention that they did that lasted multiple years, multiple rounds, combined messaging, meetings, accountability, face-to-face interactions. And we don't really know what the driver of this intervention actually was. And from a policy perspective, this is probably very impractical to scale up. It's costly, it's intensive. So what we propose doing and what we're doing right now in Zambia is to go ahead and break apart the different components of Bjorkman and Svensson's study into their different components and then roll them out in a randomized way, each as their separate treatment. So we are randomizing at the health post level. We are collecting the same types of baseline data that Bjorkman and Svensson do on staffing issues, drug shortfalls, client experiences. Then we're going to use that data to create the exact same scorecards that Bjorkman and Svensson do, gauging relative and absolute success of the clinics. And then we're going to disseminate these scorecards. And then in the N-line survey, we'll go ahead and see what outcomes look like. We have 6 different treatments as well as 1 control. The first treatment is an information-only treatment. So maybe we think that the Bjorkman-Svensson study worked because it just provided information, like Ross was talking about, that this is how your healthcare provider is doing, and we won't tell you necessarily what to do with that information. And these were going to be presented at the community level. The second treatment says, well, maybe it's not just that information is necessary, but you need to tell people how to use that information. You need to build their efficacy and explain to them that they are able and should be holding their elected officials and bureaucrats responsible. So that's the second treatment. The third treatment goes ahead and does sort of the community component of Bjorkman and Svensson's study, which is bringing people together, letting them voice their complaints, their issues, in sort of these town meeting sessions. The fourth one goes ahead and says, we're going to just work directly with the service providers to provide them work plans so that they have a means of going ahead and judging their own success and failure about how they should proceed in the coming years. And then the final treatment, or this 5th treatment, goes ahead and basically is just a replication of Bjorkman and Svensson. And then the 6th treatment is maybe it really isn't just information at the community level, but I'm just going to go ahead and give these scorecards house to house. So in all, we are working in over 700 communities and health clinics, of which almost 500 will be in treatment communities. Like I said, in phase 1, we are doing this pilot with these multiple different interventions. And then once we go ahead and complete phase 1, the mission will go ahead and scale up the entire one of the treatment arms in a randomized fashion as well. So what do we want to learn from this? What can we learn from this setup? The first one is, can we create enabling environments for healthcare provision? That's the overall. But this is broken down into, is it information that's driving these good outcomes? Is it lack of efficacy that's driving these good outcomes, or the provision of efficacy? Does it matter whether or not information is obtained privately versus in the community? And then we're going to go ahead and see does Bjorkman-Svensson's finding, which hasn't been replicated, can it be replicated in a different setting? And which part of the 2 halves of Bjorkman and Svensson's finding actually matters? Is it the community vetting process or venting process where people get together and can state what they feel they need? Or is it the ability for providers to have viable work plans? So thank you, that is all.
So Thank you very much, Mr. Mulumba. I'm used to pronounce that kind of name, so there's no problem. My name is, as we say in French, Denis Porignon, but I have an English version for you. It's Dennis Porignon. I'm working in the Health Systems Governance and Financing Department in WHO in Geneva. And I have been requested very, very late yesterday when I was jumping in my Boeing to come here and from Geneva to make a kind of overview of what we do in WHO regarding governance. So was a little bit vague. I was myself a little bit in the mist yesterday and this morning, so I will try to share with you some of the elements that I could put on the slides that you will follow. The first thing I want to share with you is something that I don't really need to share because you all know that, is the fact that WHO has done over the last 15 to 20 years a lot of efforts to put governance as a key element of the health system strengthening approach. We have already mentioned several times the World Health Report 2000, the building blocks, the World Health Report 2008, the World Health Report on primary health care, the World Health Report 2010, the system thinking of the Alliance of Health System Research and Policy. These efforts are or corporate efforts or efforts generated by the regional offices, because you know that we have 6 regional offices throughout the world, and these regional offices have their specificities, they have specific context, and they wanted to address some of these issues related to governance from their own perspective. But there are also a lot of initiatives that I can even remember of or count that are related to the specific topics that WHO is requested or mandated to deal with, like medicines, human resource, transplantations, and things like that. For the present, governance is still part of one of the major category, I mean the major objective, the major tasks that the member states have assigned her to do in the new general program of work. And it's part of the category 4 that relates to the health systems, the health system strengthening. I think that we have to put in the way we as WHO are looking at governance, the fact that the current work on governance is influenced by overall priorities as they are determined by the member states. The issue of universal health coverage, of course, is one of the most important one, but also the people-centered care approach for service delivery, the determinants of health and non-communicable diseases, and things like that, that are really at the top of the agenda of the recent resolution of the World Health Assembly in the last years. And these issues are, we have to manage these issues in the context of countries where the governance is still largely shaped by external interventions. I mean, the importance of having big groups, the Global Fund, Gavi, pouring hundreds of millions of US dollars in some countries for health systems, but majorly for diseases, has a huge influence on the way things are organized at the country level and how things are managed at the country level. And I just want to give you a short example with DRC, where I was discussing a few months ago with the director of planning, who was showing me some pictures that he took himself in the field in a regional medicine storage building. When you enter in the building, you have on the left side, you have médicaments des partenaires, medicines of the partners. And on the right side, you have our medicines. So it's clearly separated. One is given for free, the other you have to pay. One has an expiry date that is taken into account, of course, the other one also. So it's a real mess, and it's really difficult for the countries to sort this out and to overcome this difficulty. So we have to deal with that, and we are spending a lot of time to discuss with those partners in the frame of the framework of the International Health Partnership to move forward in a as possible relevant and coherent manner. From our perspective in the department, what we are trying to do is really to support the development of a health sector strategic vision or a policy at the country level, to help them to design the health system, and to work on some or broad or more specific but important issues or tools that are necessary in order to make sure that the vision and the orientation, the policy orientations that are taken by the countries are as sound and coherent as possible, so that we can avoid that when the next minister is coming in, he changes everything like it is the case in many places. The second aspect is the one related to the participation and the consensus orientation. We are spending a lot of time and a lot of energy in supporting national health forums, and we did it very recently in Moldova, in Tunisia, in Togo, in many places, so that we bring together the different stakeholders, and we are trying to ensure that we have the participation of the civil society, of course the state actors, the private sector, and we try to imply them and to make them more committed in supporting the political decision that have been made by the decision makers, that we are trying also to involve in these processes. Of course, we are trying also to work on the monitoring and evaluation and the accountability/transparency through mechanisms like joint annual or midterm review. And as I already mentioned, we are working on, we are one of the major departments working on the operationalization of the Paris Declaration principles. For that, we have developed a series of tools. Some of them are more or less well-known, like the national health accounts, and we are still spending a lot of energy to gather all the information related to that, to improving the methodology of that we started. He doesn't remember me. I remember him very well with Marty McKinnon a few years back when I was working in Rwanda. We have developed the joint annual, the joint assessment of national strategies tool. We have the One Health tool for the costing. That is an agency effort to help the countries to cost their national plans and so on and so forth. I don't want to mention all of them. We are doing that on a, I would say, guidelines or a normative way of working, but also through direct support to countries with the regional offices. And we are working with several partners like the European Commission, the government of Luxembourg, the FID, and many others in some countries to support those activities. But we have the same problem as you have. I mean, it's very difficult to measure how these policies that have been taken, that have been put in place, that have been the strategies on human resources, for example, or the a joint annual review. What is the impact of this kind of mechanism on the health of the population? The interesting thing is that, as we have said already several times, all these efforts are generating a lot of information. And I'm happy to hear that USAID is spending a lot of energy to try to sort this information and try to give them a kind of meaning. And we have to address, in some extent, how we want to demonstrate the effects. And we have mentioned some of the elements, but also the issue of contribution versus attribution. How far do we have to go in terms of analyzing the process instead of the outcomes themselves? And I was discussing with my colleagues on the table 3 this morning that it's important to try to see what is the relation between an intervention and an outcome. But what is probably more interesting is to identify the different steps between the intervention and the outcome, and to see in which extent these steps contributed or not to the final results. We have to discuss about indicators. Very strangely, we didn't mention this word yet, if I remember well, this morning. Do we use routine information? Do we use surveys? And we have largely, thanks to Sarah, discussed already the issue and the balance between the quantitative and the qualitative aspects, which for me is one of the key that we have to take into account. I don't know if I still have 1 minute to present a case, just an example that I would like to share with you, not that it will solve the problem, but maybe it will help us to understand what we try to do and the way we are trying to do it. What I would like to share with you is one of the elements that we put on paper to explain some results that was achieved in Sierra Leone in 2013, and with regard to the human resource for health in the country. We were requested by the Ministry of Health to support them to elaborate the human resource for health policy, a strategic plan for human resource for health, and an automated information system for human resources in the country. So we did that, and it had some effects in terms of leadership by helping the Ministry of Health to knowing better what kind of human resource they have, where they are posted, and how to see in the future they have to what kind of interventions they have to do in the future in terms of training or in terms of mobilizing those resources. In parallel, and even before that, an initiative called the Free Healthcare was launched in the country. And for that, there were also an analysis on the gaps in human resource that were identified. This analysis led to the mobilization of additional resources at the country level and from partners, which allowed to improve to increase the salary of the people and to increase the number of people that were recruited according or along the lines that were defined in the policy, the strategic plans, and with the support of the information system. And the result of that, the final result of that, is that we have an increase of staff density from one health staff for 1,500 to one for 620 inhabitants. This is the kind of results that we have. I think that's the kind of things that we have to look at. What are the different steps? Can we explain that increase of staff density by the different element that I have mentioned? This is really, from a practical point of view, the kind of questions that we have to look at. And I hope that in all these case studies that that have been mentioned so far, we can get that kind of information. Thank you very much.
Thanks to each of you. We have a few minutes before lunch, and what I'd like to do is to hear from any other activities or hear about any other activities that are going on that you can touch on briefly. At lunch, I'll ask the three panelists to distribute themselves into different sections of the room. And if you're interested in finding out more about what they're doing, you can certainly join them. Give them a space at first to at least take a few bites and then start engaging with them. So is there anything else that someone would like to offer to the rest of us that's already being done? Lunch has a tendency to quiet the crowd, I see. Okay. Yes, Jody.
I would love to hear, not to put any specific people on the spot. Not to put any specific people on the spot, but I think it would be interesting to hear. This is sort of USA WHO. Maybe some discussion from some of our implementing partners, perhaps, or some of the other people in the room not represented by the panel. Some of the work maybe you're doing at either at a more granular level, or perhaps if you're working on things with other donors, if you think that might be of interest, that if that piques some points of discussion, or if my talking has given you time to think, that would be, we'd love to hear that too.
So with that as a lead-in, who will step up? And we have a person right at Jody's table.
I'm Shoshana Griffith. I'm a research manager with Innovations for Poverty Action, and I manage about half a dozen RCTs. They are mostly related to environmental health, namely water and sanitation. I'll highlight a couple, though. One is looking at the effectiveness of different types of local leaders in Uganda in distributing information and coupons for water purification tablets. But it's looking at a more general question of the local governance, and we're specifically comparing religious leaders and secular elected officials. And then I have 3 sanitation projects in West Africa that look more at market structuring and price policies to improve access to sanitation services. And then more generally within IPA as an organization, we have a health sector working group and communications staff who work to pull together policy briefs that summarize the evidence generated through other studies in the research network.
Thank you.
Can I just say quickly? And then one of the grants that we're giving to academics funds the second part of the water purification study in Uganda as well. So.
Thank you both. Is there another? This table is rich with possibilities. Okay, thank you.
Transparency and Accountability Initiative is supporting some randomized controlled trials on civil society, accountability mechanisms, and impact on health with work in Tanzania. The Kennedy School of Government and the organization I work with, Results for Development Institute, are the implementers of that work.
And your name?
Marty Makinen.
Thank you. We have a spokesperson on this side.
I'm Derek Fingeroff with RTI International. A couple of years ago, a colleague and I did, this is financed by RTI, we have a project in Indonesia that works across governance and health, education, and business environment. And we did a study in 20 Indonesian districts to look at the political economy factors that influenced why local officials chose one or the other of the intervention packages that the project offered. And interestingly, I'll just summarize a couple of the findings. One, the democracy didn't seem to have too much impact. We had a model that essentially said that there were 4 political economy factors that influenced how people chose to, pursue reforms or policy changes. democracy, sort of bureaucratic initiative, looking at citizen, responsive citizen voice and all, and then the extent to which past performance influenced choices. So just a couple of the findings. One, past performance did influence it, but not in the ways that we often think of. It was good performance, not poor performance, that led people to, so if your education investment had done well, you tended to allocate the investment to more education. And we also found that in terms of comparing health and education, Indonesia is quite decentralized, so it's sort of a nice laboratory for doing these kinds of things. And we found that the health officials were not as entrepreneurial as the education ones in using national policy as a way to drive investment at the local level. So this is the revise and resubmit just got accepted. This is going to come out in International Public Management Journal sometime in the near future.
Thank you. And on this side we have another offering.
Yeah, I'm Sunita Sharma. I'm the Director of Health Policy Project. We are also looking at this, how to link policy to health outcomes. So really looking at the process side of things, like development of policies, implementation of policies, program implementation, systems strengthening, and health outcomes. So some of the examples we are looking at, one is like free maternity care in Kenya. So in terms of increased utilization of institutional delivery in that context, and also health and population policy in Uttarakhand, the way policy was developed, and then its implementation, especially the directions in the context of National Rural Health Mission, and the kinds of results it has produced in terms of institutional strengthening, capacity building, use of information in decision making, but at the same time health outcomes. So we are looking at number of also accountability mechanisms, the way they have been implemented and the type of results they have produced, and also gender governance, that's another area. So number of things now we are looking at, and then soon, I think within 6 to 8 months, we will have more information to share on that.
Thank you. Okay, we'll go there and then we'll end on this side. Well, we have 3. 1, 2, 3. Okay. 1, 2.
Yeah, my name is Michael Adelhardt, and I'm the coordinator of a global network for UHC called P4H, and members are World Bank, WHO, ILO, African Development Bank, but also USAID, Germany, France, Spain, Switzerland. So our main objective is to support countries on their journey to universal health coverage in a coherent manner. So we have at the moment about 30 countries on our radar, but there's also a couple of global activities going on, and one of them will be a knowledge, learning and innovation initiative, mainly also on governance, to try to generate more evidence from the experience we have on the ground jointly to support these countries in moving on to universal health coverage. Just an example of a question that might come up here, there will be a call for papers issued soon. What are the pros and cons to set up new institutions versus placing universal health coverage functions within existing structures? You know, these are typical practical examples that are coming out of the work we are doing for the past 5 years. And this process now, this call for proposals, will be opened up to the other partners. So USAID and the Health Governance Finance Project and all these, we try and link that up, that we can pool our resources, you know, to have a dialogue on how to generate more evidence. On the World Bank side, I see this will be mainly supported by GIZ and the Swiss as initiators, but they will open up that process. On the other partner, World Bank, of course, will also continue with its work on the UNICO. You might have heard about the Universal Coverage Program that looks more at the political economy of the UHC processes. and looking at countries that have made major gains towards universal health coverage, and how did they go about, what were the key factors. There will be some publications coming up just now, but World Bank is currently looking at a phase 2, and of course this will also be something we can share then within the network to include USAID in the programs. Third one that comes to mind is on WHO, is also this interactive guide for UHC they're currently working on, which will be basically, on one hand, looking at fast access to evidence, and which we use then also for our capacity building efforts, you know. And all this can be shared on through my, and when I work with Jody on this. Thank you.
Thank you.
I'm Mahesh Shukla. I represent LMG project, Leadership Management and Governance Project, USAID funded. We are working in Afghanistan with the committees. There are provincial health governing committees at province level, at district level, and also at community level. In our intervention, we use an organizing framework based on governing practices, mainly 4 practices: cultivating accountability, engaging stakeholders, setting a shared strategic direction, and stewarding resources. And there is a 5th practice, continuous governance enhancement. We worked with 3 provinces and 11 districts for 6 months. We measured governance through a series of self-assessments in the beginning. After 6 months, we found their governing behavior improved. They started practicing those effective governing practices. And we also measured the health system performance, because Afghanistan has a good HMIS by now. But then within 6 months, we didn't see much of improvement in health system performance. The time was too short. We could see 20% increase in antenatal visit care rate within that time. With some effort, with some rigor, we tried to find out how could we attribute this result of 20% increase in antenatal care visit rate to the intervention. We used diff in diff, difference in difference analysis, and we found that intervention indeed resulted into this increase in 20% increase in antenatal care results. We submitted this to HSS call for case studies that is ongoing right now, and we also submitted it to a journal. It is under review. Thank you.
Thank you. And we'll finish on this side.
Thank you. So Alfredo Ford with Capacity Plus at IntraHealth. And again, this is another area of health system strengthening the human resources for health. And what we did is that in realizing that FBOs contribute greatly to service delivery in many parts of the world, including Africa, we did a study in Kenya with the Christian Health Association there. And it was interesting to find that in relation to governance, the leaders were not able to ensure that their health workforce would stay. And in fact, there was some exodus to the public, to the government side because of lack of policies. So in assisting them with a policy and procedure intervention over a few years, we found that there was a great change in the culture of the organization first, and secondly, it trickled down over the years. The first thing was even an unexpected finding that what hitherto was just being personnel officers, if you like, or administrators who hardly knew anything about human resources or did mostly payroll, that they started getting training and getting professionalizing, if you like, human resources for health management. And through that process, a lot of procedures and policies were exerted, and this, changed entirely the whole, if you like, workforce condition, the conditions of the workplace and the workforce. And now we're, obviously extending that evaluation to see what effects in the actual service delivery. But just to realize that there are several strata or several steps, you know, into changing not only the culture but the actual aspects of health, human resources management.
Great, thank you. Well, Jody, you were a successful catalyst, and we're going to now pause and have lunch. We're going to come back from lunch, and we'll treat you to one more panel discussion before asking you to take on the task of identifying what you consider to be some of the gaps that you'd like to list as priorities and some of the accompanying questions that go with those gaps. So it'll be your opportunity to join in and do some constructive work building on the things that you've already heard this morning. So lunch is right outside, if I'm not mistaken. And again, if the panel here is willing, I'd ask Dennis to situate himself on this side, and you may be joined by some folks. And Nicole, if you want to take the middle section, and if you'll take Joe this side for folks that are interested in hearing more. And there may be other clusters that you want to form. The time now, by the way, is almost 12:30, so let's plan to get back together at 1:15, and I think we can then move swiftly ahead and finish up things on time. So food's waiting for you. Again, you can join our panel that's here or perhaps some other clusters in different spaces in the room. Until 1:15, we'll have you back.